Dear colleagues and friends, welcome to you all. I am Norbert Claude Gorin from the Department of Hematology at Hôpital Saint-Antoine in Paris, and also I am the chair of the EBMT Global Committee. This webinar is the third one sponsored by Air in Space, and if you remember, the two first dealt on COVID infection and vaccination for the second one. The present one focuses on fungal infections. I'm pleased and honored to chair it. So I will start with a few introductory slides. First of all, my disclosures for this presentation, and then our usual COVID dashboard, which I updated as of June the 21st, 2021. From what we see, it is likely that unfortunately we will soon reach 200 million patients with the COVID infections, and with a death rate of 2.2%, we unfortunately will reach probably 4 million deaths. Regarding vaccination, this slide shows per country the number of vaccination doses administered for 100 people, and whenever it goes over 100, of course, it just means that some people did already receive 2 vaccinations. Now, having just given these statistics, we go to our interest in the day, fungal infections. Our program is here. We have 3 worldwide renowned speakers, and I'm grateful they accepted to participate. Professor Olivier Lortholary from Necker Hospital and Pasteur Institute will review the scope of fungal infections in hematology and probably a stem cell transplant unit. Professor Fanny Lanternier from Institut Pasteur Paris is an expert on rare and dangerous fungal infections such as Mucomycosis, Pneumocystis, Girovecii, and Fusarium. And finally, Professor Monica Slavin from Melbourne will review the drugs we have against fungal infections and probably will tell us about the new tools we may have. The field of fungal infection, in fact, is extremely complicated, and I will summarize with 4 slides. To introduce the speech by Olivier Lortholary and Fanny Lanternier, I would like, first of all, to indicate the risk of fungal infection in relation with the disease behind and the patient status. And as you can see here, if autologous stem cell transplantation is indicated as being low risk for fungal infection, on the other hand, chronic lymphocytic leukemia under ibrutinib, or even most of all, allogeneic stem cell transplantation is very high risk. And of course, graft versus host disease. But we also have to cope with an incredible number of new revolutionary anti-tumor drugs that have been approved in the last 5 years. And each of them brings potential additional immunosuppression, complications, and favor fungal infection. And as an example, you would take CAR T cells, which destroy with the anti-CD19, for instance, for the treatment of ALL B cells. To introduce the speech by Monica Slavin, this slide was presented at the last annual EBMT meeting by Johan Mertens, and it shows you the currently available antifungal drugs. I'm sure that Monica Slavin will detail this and add additional drugs. I selected here one slide which indicates that not only it's difficult to diagnose fungal infection, not only it's difficult to find the tools to treat the infection, but in addition, we have unfortunately interactions between several drugs, antifungal drugs, and new anti-tumor drugs. Here, for instance, if you consider the anti-BCL2 venetoclax, and you combine this with our new antifungal fungal agents, you have that because you see that because of the strong CYP3A inhibition, we have to adapt the dose of venetoclax to the antifungal drug we use. Finally, I will show you the experience of fungal infections in China, in Beijing, as reported by Yuqian Sun, who spent a year in our institution and went back, did a multi-center retrospective analysis of all these invasive fungal infections. And I have two slides. You see here, for instance, the two curves at the bottom in green and blue represent the incidence of fungal infections following autologous transplantation or HLA-matched related sibling allogenic transplant. But in red and purple, you would see unrelated transplants and haploidentical transplants with a considerable incidence of fungal infection. And in addition, here the survival curve, but this time in relation to the diagnosis of fungal infections. And because, as Professor Lortholary will probably tell you, the diagnosis of fungal infection is usually extremely difficult, you will see here the survival by category. And we have proven or probable infection disease, possible infection disease, suspected invasive fungal infection receiving antifungal therapy, and at the end, non-suspected fungal infection with therefore no antifungal therapy and probably diagnosis at post-mortem examination. So I am ending my talk. Not surprisingly, prevention is the most important tool we may have. And I cannot help showing you here some material we all have in our transplant units in France, but this is in Suzhou in China, where you can see several plasma units which destroy particles of all kinds, bacteria, fungi, and also droplets carrying viruses in an oxygen plasma-built environment. And here in Shanghai, biocare rooms with negative pressure in the room to protect medical and nursing staff of the Regin Hospital. So this is my introduction. And of course, Professor Lortholary will now give his speech, but I would like to remember you that we have a general discussion at 3 p.m. from about 3 to 3:30, and you can ask your question all along the presentation. Thank you.
Good morning, everybody. My name is Olivier Lortholary. I'm professor of infectious diseases and tropical medicine at the University of Paris. And it's a pleasure to talk on invasive aspergillosis in hematology, the 2021 vision. My disclosure. So what are the consequences of mold infections in hematology and particularly invasive aspergillosis? Of course, these diseases are difficult to diagnose, are associated with cost and increased mortality. If we look to the distribution of invasive fungal infection in France over a decade, we were able to do it with the public health authorities involving a large number of IFD. And you can see that invasive aspergillosis represents number 3 of invasive fungal infections in France. If we look to the distribution of fungal infections with the National Reference Center vision, you can see that invasive aspergillosis is also number 3 following fungemia and pneumocystosis, so number 3 among invasive mycosis. Importantly, in physiology, there are important cells involved in the protection against fungi, and especially aspergillus, such as neutrophil, such as macrophages, such as dendritic cells, and more recently, over the last 20 years, the role of T lymphocytes and particularly CD4, has been illustrated. This is important to recognize that almost all important fungi responsible for human infection interact with the immune cells through receptors, which are present in the membrane, such as dectin receptors, such as TLR, and Aspergillus can be controlled because such complex immunity is present with the dendritic cells, which provide a link between innate and adaptive immunity. So what are the risk factors for mold infection and aspergillosis, particularly, generally speaking? You can see on this picture that most of the cases will come from the hematology world, such as those with acute leukemia or those allo stem cell transplanted. Infection such as invasive aspergillosis are acquired exogenously through inhalation of spores until alveolar macrophages from the community, from the healthcare system, and sometimes from travels. What are the real-world data regarding the incidence of mold or the proportion of mold infection and aspergillus, particularly among allogenic hematopoietic stem cell transplant recipients? You can see that 5 to 15% of allogenic stem cell transplanted patients do develop aspergillosis in the absence of prophylaxis. This is also clear for acute myeloid leukemia and acute lymphoblastic leukemia, and we will see the situation of other hematology disorders later on. Importantly, the distribution of fungal infection shows that over time, between 2001 and 2010, there is an increased incidence of invasive aspergillosis, both in hematology patients on the A part of the slide and in hematopoietic stem cell transplant recipients on the B part of the slide. If we look to the distribution of invasive fungal infection among allo stem cell transplant recipients in the States, you can see that the number one fungus is Aspergillus, while others represent 66%. If we look to this summary table from Kyra, published in 2011, you can see that the incidence measured in percentage of aspergillosis among allo stem cell transplant recipients varies according to center from 2.6% to 13.5%. So what are briefly the prophylactic recommendations of invasive fungal infections in hematology? Most of, just to say that all international guidelines on antifungal prophylaxis in acute myeloid leukemia and allo hematopoietic stem cell transplantation recommend with the A1 rank posaconazole. This is true for SIL3, German recommendation, US recommendation, British recommendation as well. But importantly, we know that the diagnostic workup of patients under antifungal cover is different. So that means that there is no need to monitor antigen galactomannan detection in serum as well as PCR in those prophylaxed with posaconazole or even other azoles. Importantly for our practice, there are well-known breakthroughs invasive fungal disease in patients receiving posaconazole primary prophylaxis. When the story starts, we thought that it was related to low serum concentration of prosaconazole, but in fact, some patients have adequate concentrations in the serum and do develop breakthrough invasive fungal diseases such as Fusariosis or Mucormycosis. There is an interesting work performed at the Duke University Center in the States, conducted by Frédéric Lamotte and published 4 years ago, which clearly showed that invasive mold infection were clearly different according to the exposure to an antifungal. And you can see that the distribution of fungal pathogens among breakthrough invasive mold infection shows, for example, the emergence of Aspergillus ustus, a multiply-resistant pathogen. Is the clinician failing to recognize the emerging host? We hope not. And it's interesting to look to what happens in autopsy studies of patients with hematological malignancy. This is a nice study from the Russell Lewis group in Houston, showing the 20-year US monocentric autopsy study among hematology patients. And you can see on the left part of the slide that according to the date, there is a dramatic decrease of patient developing aspergillosis at autopsy. What about tobacco? Tobacco, we recently published in a CID an important meta-analysis, which was based on 25 studies reporting on the association between smoking and AFD, with 18,000 patients participating. And the meta-analysis showed a significant association between smoking and the risk of IFD, with a pooled risk ratio, as you can see on the slide, of 1/41. So it's not good to smoke when you are an hematology patient. Interestingly, among hematology patients, there are new risk groups, and I want to illustrate the emergence of chronic lymphoid leukemia as an underlying disease supporting the occurrence of invasive fungal disease. Why chronic lymphoid leukemia? Because now these patients are more intensively treated, receiving purine analog, receiving the combination of anti-CD20 antibodies and other chemotherapy, fludarabine plus cyclophosphamide plus rituximab, for example. Some of these patients are also allo stem cell transplant. And in fact, the consequence of this event is that we created among hematology patients new SCID who are ambulatory with neutropenia, severe immunosuppression, and hypogammaglobulinemia. That means that if we look to the current risk factors of invasive aspergillosis in France, it's a study we published 10 years ago now, involving almost 400 patients. You can see that the proportion of hematological malignancy among all cases of invasive aspergillosis is pretty high, around 80%. And you can see that lymphoproliferative disorders now represent a total of 22% of patients developing aspergillosis in our country. What are the drug signals among patients with lymphoid malignancies now? There are 3 agents which are involved in the occurrence of invasive fungal infection: ibrutinib for invasive aspergillosis, pneumocystis, and cryptococcosis, idelalisib for pneumocystis, and anti-CTLA-4 antibodies for PGP. If you look to other recent drugs in hematology, these drugs, such as venetoclax, or brentuximab, or blinatumomab, are not associated with a worrying signal of invasive fungal infection. Of course, COVID has complicated the situation, and we have now hematology patients with pulmonary aspergillosis who are intubated in ICU and who have developed COVID-19, and it's a separate topic. I have no time to cover it in detail today, but it has become a major important topic among the last months. What are the other medications, and especially biotherapies, which have been associated with an increase of invasive mold infection? TNF-alpha blockers, rituximab and other immunosuppressive therapy have been associated with PGP and not invasive aspergillosis too much. IL-17 targeted agents are not associated with aspergillosis but by mucocutaneous candidiasis. And again, ibrutinib and idarucizumab involved in the occurrence of pneumocystis, and for ibrutinib, aspergillosis, and particularly among aspergillosis patients, 40% of them developing cerebral localization. Among the hematology population, there are also patients with primary immune deficiency, such as chronic granulomatous disease and STAT3 deficiency. We know well this disease in our department, and unfortunately, when these prior children become adults, the incidence of aspergillosis has not decreased and is around 40% of patients when looking to the entire life of this chronic CGD patient becoming older. So what is the management of invasive aspergillosis in hematology? And if we look to mortality data, overall 44% of patients still die in the hematology setting from aspergillosis. First of all, the first measure should be to improve immunosuppressive status by reducing or withdrawing steroid therapy and reduce other immunosuppressive agents if feasible. To start early antifungal therapy, the benefit of early therapy has been suggested since 25 years now, and give the most appropriate therapy. So briefly, I make you reminding that voriconazole was compared 20 years ago to amphotericin B and showed a non-inferiority and even a superiority. Superiority because voriconazole has a great tissue distribution, as you can see, in lungs, spleen, kidneys, bone, brain, and cerebral spinal fluid. The impact of initial therapy of invasive aspergillosis has been clearly demonstrated by Raoul Herbrecht in the seminal paper in New England 2002, and that was confirmed by our data. Also, the power is less significant, clearly showing that the voriconazole, compared to other antifungal use as a primary treatment, has a superior effect and superior survival. This is also illustrated by the Strasbourg study published by Nivois. This has been also demonstrated for the early survival, which was better in voriconazole-treated patients at Saint Louis Hospital in Paris. So voriconazole was associated with increased survival at 12 weeks, but not at 12 months. So the decrease has been reported to be by 70%. The problem of Aspergillus in hematology, at least in several countries, is the occurrence of azole resistance. And you can see the world map published 4 years ago showing the distribution of azole-resistant Aspergillus fumigatus with 2 seminal mutations described on the screen. And there are different AA or TR substitution in CYP51A, making different phenotypes. And according to phenotypes, we have the close correlation with the mutation. So detection difficulties means, do we have to use phenotypic method or genotyping? Of course, at the reference center, we use both, and we are here in France to confirm the occurrence of such resistant strains. Aspergillus fumigatus resistant is a particular problem in Netherlands with increased mortality at 6 weeks or 3 months. And the laboratory today can help by culture, can help by PCR, and looking for mutation. If the mutation are present, voriconazole cannot be used. If the mutation is not here, voriconazole can be continued. So the PCR used in practice is aspergillus, for example. So no mutation, continue voriconazole. Mutation, consider to switch for liposomal amphotericin B, or with an attitude I don't recommend myself, which is the combination of voriconazole and echinocandin. Combination therapy for invasive aspergillosis has not been shown to be successful, so still monotherapy as a first-line strategy. And there are important considerations for voriconazole. Therapeutic drug monitoring has to be secured. We have to look to hepatic dysfunction, drug interactions, because voriconazole is metabolized by 3 cytochrome isoenzymes, and monitor long-term therapy because fluorosis and skin phototoxicity and related cancer can occur on a long-term basis. Now, there is an alternative to voriconazole since some few years now, which is izabuconazole, which is less metabolized by cytochrome system, so CYP3A4, CYP3A5, so less interactions than voriconazole. And izabuconazole versus voriconazole for primary treatment of aspergillosis has been shown to be non-inferior. So we are secured that izabuconazole can be an alternative to voriconazole first-line therapy. What about increasing the dosage of ambisome liposomal amphotericin B in invasive aspergillosis? So the outcome is not different than with conventional dosage. So please continue to use 3 milligrams per kilogram per day of liposomal amphotericin B if you cannot give izabuconazole or voriconazole. So the recommendations are obviously A1 for voriconazole as first-line therapy, or A1 for izabuconazole. Practice guidelines from the IDSA also recommend voriconazole. And also ECMID ECMM recommend izabuconazole or voriconazole. To end my talk, just to mention that 3 months ago, an important trial, a randomized prospective double-blind, double-dummy, has compared posaconazole with voriconazole for primary treatment of invasive aspergillosis. The primary objective was to look for cumulative all-cause mortality until day 42 between 2013 and 2019. The mortality was indeed 15% in the POSA group and 21% in the VORI group, which was highly significant, while side effects were less observed in POSA group compared to VORI group. So POSA is non-inferior to voriconazole and better tolerated as a primary treatment of invasive aspergillosis among hematology patients. So to conclude, I think it's important that we try the few ID physicians working with hematologists to a more individualized approach of invasive mold infection and particularly invasive aspergillosis in hematology patients. So we deal with prior antifungal therapy, we deal with resistance, we deal with PKPD, we deal with immunosuppression and immunoreconstitution, we deal with host genome. So all these parameters have to be integrated into equation. And the last but not the least, I wanted to create a group which name would be Advance Against Myth Aspergillosis. So you can see that managing appropriately a patient with invasive aspergillosis needs the contribution of radiologists, clinicians, biologists, and endoscopists. Thank you very much for your attention.
So I will talk about the rare invasive fungal infections. One word about the epidemiology of this infection in hematological malignancy. These infections are recently modified due to antifungal prophylaxis, also the better fungi identification, and also early diagnosis with non-invasive diagnostic tools. There's also new antifungals or new formulations of antifungals. Going to French epidemiology of invasive fungal infections, you can see here that 43% of patients developing this infection have hematological malignancy or cancer. And so concerning the rare mold infections, mucormycosis, fusariosis, and Cytosporiosis are between 1% and 3% of all invasive fungal infections. So I will focus on those three infections. You can see on this report that if you will look at patients developing invasive mold infections that are either breakthrough or non-breakthrough, the epidemiology is very different. The breakthrough mold infections include less infections due to aspergillosis. Mucorales are the first with other molds leading cause of breakthrough mold infection. Then we find Fusarium and Cytosporium. So when we take care of a patient we suspected to have invasive mold infection, to know if the patient is receiving active mold prophylaxis is very important. So now I will focus on the three main mold rare invasive fungal infections that are mucormycosis, Cytosporiosis, and fusariosis. Concerning the mucormycosis, so hematological malignancy represents half of the patients. If we now look at the location of the infection in patients with hematological malignancy, the most frequent location is lung, then disseminated infections that represent a quarter of the patients, and rhinocerebral or cutaneous infections are less frequent. These infections are complicated with very high mortality because survival is only 43% at 3 months. You can see on this graph that patients with hematological malignancy, which is the red curve, have a lower survival than other patients. If we now focus on hematological malignancy patients that are hospitalized in intensive care units with mucormycosis, the survival probability is even lower, as you can see here. If you compare patients who had allogenic stem cell transplants, the survival rate is even lower. You can see them on the red graph. It is important to have in mind that mucormycosis, even in hematological setting, can be healthcare-associated infection. Then the location is different. It's mostly skin infection, as you can see on this photograph. You have to have in mind that there can be outbreaks. So when you have a hematology patient with skin infection, it's important to try to find the source of the infection to try to avoid an outbreak. The clinical presentation of mucormycosis can be lung, rhino-orbitocerebral, skin, digestive, or disseminated. Concerning the rhino-orbitocerebral form, it's mainly invasive sinusitis with cranial nerve palsy, palatine necrosis, and terminal necrosis. Exophthalmia and chemosis are associated with higher mortality. On the CT imaging, you have invasive sinusitis with bone lysis. The endoscopy will be very important for diagnosis, being able to show some necrotic tissues and to take samples to prove the diagnosis. Concerning the lung infections, the computed tomography will help to guide the diagnosis. It can be non-specific images, but also the reverse halo sign, which is not pathognomonic, but highly evocative of mucormycosis. In this study that compared pulmonary mucormycosis from hematology patients in either neutropenic or non-neutropenic patients, you can see here that this reverse halo sign is highly associated with neutropenia. So you really need to advocate mucormycosis if you face a reverse halo sign in a neutropenic patient. As we talked about the COVID area and mucormycosis, it was seen that cases of mucormycosis were reported in COVID patients, with those first reports in diabetic patients who received corticosteroids for severe COVID-19, and that after between 10 and 15 days developed mucormycosis, with these 2 cases of rhino-orbitocerebral mucormycosis and 1 case of gastrointestinal infection. Lung infection is also possible, as you can see here in this male who had severe COVID infection and cavitary lung rhizopus infection. As you probably heard, there's a very important emergence of mucormycosis in India in COVID-19 patients who are mainly diabetics treated with corticosteroids for their COVID-19 and who develop rhino-orbitocerebral infection. So now declaration is mandatory for these patients. There's this bigger study who looked at SARS-CoV-2 patients with uncontrolled diabetes and corticosteroids who developed invasive fungal infection of the maxillofacial region. You see that mucormycosis is the first infection. In this larger series of 41 published patients with COVID-19 associated mucormycosis, you also can see that most patients had rhino-orbitocerebral or rhino-orbital infection, but only a very few patients had EORTC risk factor, so very few hematological malignancy patients in this series. How to diagnose mucormycosis? So you need a sample for the site of infection, and there's these very interesting tools that helps to do earlier diagnosis, which is mucorale qPCR that can be performed in serum of patients. And in this publication, you can see that 81% of mucorale patients had qPCR positive in serum. And then this qPCR was positive 9 days before mycological diagnosis. So it can help to diagnose this infection earlier. The negativation of the qPCR is associated with better survival. This PCR was studied for screening of patients in critically ill burns patients, and you can see that in the period where patients were systematically screened, the mortality of patients due to mucormycosis did become lower. How to treat mucormycosis? So it's very important to treat early. It's really an emergency that has to associate the control of the risk factor, a surgery for most of locations, and the choice of the good antifungal. Concerning surgery, it's very important in rhino-orbitocerebral infections. You can see here that patients who had local control of infection and extensive surgery with a second look had a better survival. The question is, when should we perform surgery in pulmonary infection? So there's not really a clear answer for that. In this publication that looked at both pulmonary aspergillosis and mucormycosis, patients were either operated in emergency or with elective surgery. So in these publications from mucormycosis in intensive care units, they found that patients that had surgical intervention had really better survival. We know that there's always a bias as the most severe patients cannot be operated. However, even in the hematological malignancy group, the survival was really better for patients who had surgery. So early treatment is associated with better survival. Concerning the MIC of the different mucorales strains, you can see that MIC to posaconazole and polyene are very low, compared with Izabiconazole MIC that are quite high. Concerning the clinical trial, there's the Ambizygo clinical trial that evaluated high dose of liposomal amphotericin B in mucormycosis. And that could evidence that after 3 weeks of the level of response was 48% and death was 38%, so which is quite encouraging. Concerning the Izabiconazole in mucormycosis, there's a VITAL study that studied efficacy of Izabiconazole in primary treatment of mucormycosis, and that assessed that the response after 42 days of treatment was 14%. So comparison of the two studies shows that the level of response to Izabiconazole is lower. However, this is not a comparative study. So we just should be cautious when using Izabiconazole in first line for treating mucormycosis. In these global guidelines for the diagnosis of management of mucormycosis, you can see that the recommendation is first surgical debridement with clean margins for mucormycosis, and then liposomal amphotericin B, high dose, mostly when there's brain involvement, it's 10 milligrams per kilogram per day. Otherwise 5 milligrams per kilogram per day, or when not possible, Izabiconazole IV. So in conclusion, for mucormycosis, it's very important to have a radioclinical suspicion very early. This is a diagnosis emergency. You can do serum PCR and also take specimen at the site of infection. Then it's therapeutic emergency that has to combine surgery and antifungal treatment with liposomal amphotericin B high dose. And then you can step down when the PCR is negative. I will now go to Fusariosis, which is another emerging mold infection, which is really mostly occurring in hematological malignancy patients. The site of infection are the lung, the skin. There's an association with skin lesions and invasive infection. The survival really improved with an increase of survival from the emergence of voriconazole use. Concerning the diagnosis, you also need a specimen at the site of infection. So whereas there's the skin involved, you biopsy the skin. The blood culture are frequently positive. And an interesting tool can be the positivity of the galactomannan antigen. Fusarium MICs are always very high to all antifungals. So the analysis of the MIC of the different strains to the different molecules is not necessary and will not be helpful to decide the treatment. Voriconazole from this study that was associated with better survival of the patient is the cornerstone of the treatment. Concerning the Cytosporiosis, there's a very important, the strain of the infection is important because the epidemiology varies according Cytosporium species. So collecting 19 cases of invasive Cytosporiosis in France, we could show that in our country, half of the patients were infected with Cytosporium apiospermum, 17% with Cytosporium boydii, and 15% with Lomentospora prolificans that was previously known as Cytosporium prolificans. We could evidence that Lomentospora prolificans was associated with malignancies, mainly acute myeloid leukemia, associated with disseminated infection with frequent positive blood culture in most of the patients, and that 3 months mortality was very high, 67%. Concerning Cytosporium apiospermum, it was associated with malignancy, lymphoid leukemia, chronic lymphoid leukemia. It was associated with skin or isolated osteoarticular infection, and the fungemia was very rare. By contrast, Cytosporium boydii was associated with transplantation, with isolated pulmonary infection, and fungemia was more frequent. Concerning the survival, it was associated with the mortality was associated with the neutropenia, with the dissemination of the infection, and by the infection with Lomentospora prolificans. If we focus on Cytosporiosis in hematological malignancy patients, half of the patients were neutropenic, a third of them had breakthrough infection, half of the patients had localized infection that was mainly lung infection, and half had disseminated infection. When you focus on disseminated infection, you can see that a quarter of the patients had brain involvement. Therefore, brain MRI is important when taking care of those patients. The mortality was 48% at 3 months. So concerning all the cohorts in the disseminated infection, 2 locations were very important. CNS infection that was present in 40% of disseminated infection, and cardiovascular infection present in 33% of infection. If we focus on Cytosporiosis in Australia, you can see that epidemiology is very different. That is important to note that the epidemiology of these molds that come from the environment will vary according to the country. In Australia, there's an emergence of Cytosporium aurantiacum, and you can see in this comparison of Cytosporium aurantiacum to Cytosporium apiospermum that in this cohort, hematological malignancy patient was very low, with only 1 or 3 patients in the different groups. So for Cytosporiosis, there's a diversity of clinical presentation. The dissemination to CNS is very important. Mortality is half of the patient, and there's an important influence of the infected species. So in conclusion, for invasive mold infection, there's an epidemiological modification. The new non-invasive diagnosis tool will help for early diagnosis. There's a very important of sampling the tissue to go to the species identification. It's important to be aware of the MIC interpretation. Thank you for your attention.
Hello, everybody. My name is Monica Slavin, and I work in Melbourne, Australia. Many thanks to the organisers for inviting me. It's a great honour to be able to talk to you today about new therapeutic developments for the treatment of fungal infections. So in summary, I'm going to talk a little bit about the antifungal pipeline, gaps in current treatments, what new treatment options are in clinical trials currently, a little update on what's new in the azoles, and briefly touch on other advances before finishing. So really, when we look at the antifungal pipeline, we can see that there's been no new antifungals licensed since the echinocandins back in 2000. There was a rapid development between 1980 and 2000 of many new classes of drugs, but since then, we haven't really had anything new. Just to let you know that now in 2021, we do have multiple new classes of antifungals, and several of these are now in phase 2 and 3 clinical trials, and I will focus on these new ones today. Just to refresh about the current gaps, I think I'm speaking to an audience that really knows the limitations of our current antifungals, but certainly, especially with the use of broad-spectrum azole prophylaxis, we are seeing resistant moles that are intrinsically resistant to the azoles we use in prophylaxis breaking through. And some of those would be Lamentaspora prolificans, which used to be known as Scedosporium prolificans, Fusarium, Mucomycosis, Scopulariopsis, and of course in Europe we're seeing increasing reports of azole-resistant Aspergillus, particularly from Dutch and Belgian centres. We've also seen the emergence in the last few years of Candida auris, and of course Candida species that are resistant to the echinocandins. We are well aware of the drug-drug interaction problems, particularly with the azoles, which are metabolised by the cytochrome P450 enzyme system, and which many of the drugs that we use in transplantation will interact with. There's also the requirement with our current medications, often for IV dosing, particularly for amphotericin B and the echinocandins, which does limit their use in the outpatient setting. And of course, toxicity, particularly with the amphotericin B agents, electrolyte imbalance and renal dysfunction, as well as the hepatotoxicity that we see with the azoles. So all in all, we do have limitations with our current antifungals. Now, this is a schema of the fungal cell, and I'll just walk through it slowly in that it's talking about what the classes of drugs that act as antifungals and where they act, and pointing out some of the newer agents that we're going to talk about today. So we're very familiar with the polyenes that act on the fungal cell membrane, and the azoles, which also inhibit the formation of the fungal cell membrane. But we do have a number of new classes now in development, some related to the echinocandins that affect the cell wall function, the production of beta-D-glucan in the fungal cell wall. We see a new modification of the echinocandins to produce longer-acting drugs with resifungin. And we also see abrexafungerp, which acts in a different part of the pathway for glucan synthase than the echinocandins we're familiar with. We also have some exciting new drugs that actually act on the structure and integrity of the fungal cell wall with these fungal surface proteins. And these are important anchor proteins providing structure to the fungal cell wall. And so we have a drug that inhibits the production of these called phosphomanogepix. So this is a completely new class of action. Likewise, with olorifim, we also have another new class of action. That is a drug that inhibits pyrimidine synthesis and so affects production of the components of the fungus that are essential. We also have another class of drug which takes advantage of siderophores. So all fungal cells take up iron, and there is a special pathway for iron to enter the fungal cell in siderophores. So this drug takes advantage of this pathway to gain entry into the cell, but we don't know its exact mechanism of action. And this is another new drug that's in studies for the treatment of Aspergillus. So as you can see, the field is changing, and we're seeing drugs that act in different mechanisms to what we're familiar with in the past. So just to recap on those, we talked about resifungin, which has improved features from the other echinocandins. There's a structural modification that means that it's got a very long half-life and can be given weekly. And this may be an advantage for outpatient therapy, for example. We also have these new drugs that act on new targets and novel mechanisms of action, such as brexafungin, which is currently in trials for combination therapy. Phosphomanogepix, which is again totally new on the GPI anchor synthesis of the cell wall, which seems to have good activity against many of the resistant molds, as does olorifim, the drug that acts on pyrimidine synthase, again very useful for the resistant molds. So I've just summarised these new fungal cell wall drugs in this slide, looking at where they're currently being studied. And I think with the resifungin, the modification with weekly dosing, we see it being used in the treatment of invasive candidiasis. There's a phase 3 study comparing it to caspofungin. And of course, there's an interest in using it in prophylaxis in stem cell transplant. And there's a study that's been designed to look at it in that setting. Reason being that it does have some activity against Aspergillus and PJP, as well as Candida. So maybe an option for once weekly dosing as prophylaxis. So that study, I think, is yet to begin. Turning to the new glucan synthase inhibitor, brexafungin, again, this may have some advantage in the resistant Candida. It's also very effective for PJP and is synergistic for Candida and Aspergillus. And so it's currently undergoing phase 2 study for combination therapy to treat invasive pulmonary aspergillosis, as well as study in refractory or intolerant Candida infections, including Candida auris. As for phosphomanogepix, the cell wall structural protein inhibitor, this is also quite a broad spectrum agent and seems to have some activities against many of the quite resistant molds, including Fusarium, Cytosporium, Lamentaspora, some Mucorales, and is currently being in phase 2 trials for candidemia and for refractory or intolerant mold infections. So these are the new drugs that act on the fungal cell wall. There are the new drugs also that act on fungal metabolic pathways, and I've mentioned olorifim, which is a pyrimidine synthase inhibitor, and this seems to have activity against some molds, but not all molds, particularly for Aspergillus and Lamentaspora, Cytosporium, and some Fusarium. But it does have gaps, and so where we're using this to treat a highly resistant mold, we still need to consider whether the patient might need Candida cover if they're, for example, requiring anti-Candida prophylaxis. So it does miss out on the yeast, it doesn't cover the yeast, and it doesn't particularly cover Mucorales. So this is also in a phase 2 study at the moment, which is enrolled over about 100 patients with refractory or intolerance of treatment for mold infections, and is about to start a phase 3 study in aspergillosis compared to liposomal amphotericin B. The final drug is that very interesting one that uses the siderophores, the ion uptake mechanism, to get into the cell, and it's not quite sure how it actually acts once it's within the cell, but it does seem to have activity against Aspergillus and some of the drug-resistant Candida. Now, there was a study underway, a phase 2 study, looking at it in aspergillosis, but because of slow recruitment, that study is temporarily on hold, I believe. But I still think this could be quite an interesting and valuable drug to study further. This is just an example of one of our patients who was actually on the olorofim study, the pyrimidine synthase inhibitor, which has activity against some of the resistant molds. And this was a lady who was undergoing hypercvad chemotherapy for T-ALL and developed a disseminated lamentaspora infection during her neutropenic phase. She was treated with combination antifungal therapy, including voriconazole, terbinafine, and echinocandins. But 6 months later, presented with progressive infection, she developed an L4-5 discitis and osteomyelitis, despite being on continued antifungal therapy and having her chemotherapy paused. So you can see here the very hot increased uptake on PET in the vertebra here, and over time, the reduction in uptake, which was accompanied by symptomatic improvement. And she received this agent for a year. So I want to talk a little bit about the azoles because there is some new information on the azoles in antifungal therapy. The first study to mention, which I'm sure you're probably aware of as it was published a few years ago now, is the Izabiconazole versus voriconazole multi-centre non-inferiority trial. And this was for mold disease, but actually when you look at the patients enrolled, they were predominantly pulmonary aspergillosis patients. And this drug was non-inferior. I've just cut out the primary endpoint here was the day 42 all-cause mortality, which was similar across the two drugs, hence reaching non-inferiority for Izabiconazole. And when we look at the Data Review Committee assessment of overall response to the fungal infection to the drug, very similar response rates with complete partial response rates here shown. So overall, a favourable result for Izabiconazole. But what was clear from the trial is that there were less skin issues, less eye and visual issues, and less hepatic dysfunction with Izabiconazole than voriconazole. Although these side effects still did occur, they were less frequent. There was also some other advantages for Izabiconazole. The one disadvantage is it's more expensive, but certainly there are less drug-drug interactions because it's primarily metabolized by CYP3A4 and doesn't have the wider effect on CYP enzymes that voriconazole has. And one interesting feature of it is that it shortens QT interval, where we know all the other azoles tend to prolong QT interval. And the most recent study to be done is another non-inferiority study comparing voriconazole and posaconazole in the treatment of aspergillosis. And again, the majority of patients in this trial had pulmonary aspergillosis. And again, non-inferiority was shown for posaconazole. And again, less treatment-related adverse effects were seen with posaconazole than voriconazole. But there are some cautionary notes to take into account when we think about using posaconazole as our first-line treatment for invasive aspergillosis. One of them relates to the poorer CNS penetration of posaconazole than voriconazole. So if we had a CNS lesion, voriconazole would still be our first-line choice in that situation. And of course, recently described has been a syndrome of pseudo-hyperaldosteronism with posaconazole. This is an interesting syndrome, and it's really only been seen since the tablets have been available, and we're seeing patients who are achieving higher serum levels with the tablets than what we previously saw with the oral solution. And this syndrome is associated with a low potassium and a high blood pressure and feelings of weakness, nausea, vomiting. And more commonly seen in patients who have hypertension and in the elderly and in people who achieve quite high serum posaconazole levels. So just something to be aware of in that situation. What about the new interventions? Certainly we've heard about adoptive T-cell therapy as an option for many different infections after allogeneic stem cell transplant. And also there's a lot of research going on currently with the microbiome and mycobiome, looking at immunity and looking at risk for infection. So I'll just briefly touch on these before I finish the talk. Looking at T-cell adoptive immunotherapy, we can see that there over the years have been multiple reports of clinical scale production of Aspergillus-specific T-cells for invasive aspergillosis. And although a lot of groups have described producing these T-cells, there's probably much less experience that I could find in the literature with actually using them in patients with infection. Certainly, one study from Italy a few years ago described using them for treating invasive pulmonary aspergillosis in 10 patients and described a better outcome in these patients than in controls who did not receive the T-cells. A small study, but I guess something that showed promise in treating aspergillosis. And recently there's been a study from Australia looking at polyfunctional T-cells with activity against many infections, including viral and Aspergillus fumigatus as prophylaxis. And these were donor-derived T-cells given to 11 patients. And again, proving that there was active immunity in these patients who received the donor-derived T-cells. And for Aspergillus, no infections, but again, a very small, probably more proof of principle study than anything that we could take definitive answers from. But I think it does show that there is a potential role for adoptive immunotherapy, both as treatment and prophylaxis. But I think the limitations are actually the time and the cost of manufacturing these T-cells. And as potentially the technology improves, we may see them being used more widely in practice. The last point I wanted to talk about was the microbiome. And some very nice work came out recently from Sloan Kettering, probably confirming what we all knew about invasive Candida and patients undergoing allogeneic stem cell transplant. But it's very nice, elegant work proving the point. And this was following a cohort of patients who developed candidemia. And here in the grey is the time the patients developed candidemia. And here on the y-axis is the log of Candida from their stool, from the patient's stool. And you can see, and these are the transplant days along the x-axis. And you can see that everyone starts off with relatively low log of Candida in the stool, and over the course of the transplant it increases, and we really see the peak time around the time of candidemia. And this group then went on to genomically compare the Candida in the stool and the Candida in the blood, showing that it was genetically the same. But what's interesting is that this was associated also with decreased bacterial burden. So as the Candida increased, the bacteria decreased in the gut microbiome, as did the diversity of bacteria seen, especially the diversity of anaerobes. So this does indicate that there might be an opportunity to intervene here and modify the microbiome in order to prevent this invasive Candida infection. So I think that's some very interesting work for future. And the last study I wanted to point out is another really interesting one about the gut microbiome and immunity to Candida infection. And this was done by a global group, including workers from Europe and France, who contributed to these very interesting studies looking at the receptors for Candida in the gut. So these are the gastrointestinal tract cells. Here are the particular receptors, and it's been shown that CARD9, CX3CR1, these macrophage with these markers are really the receptors for the Candida, and they take up the Candida, carry it to the spleen where specific immunoglobulins are made and released systemically. And this seems to be very critical to preventing against disseminated Candida infection, so that in the patients and the mice in these studies that did not have these CARD9 macrophages, they would get a disseminated Candida, including Candida meningitis, compared to those that had the CARD macrophages and produced the antibodies. They were relatively protected against disseminated Candida infection. So again, very interesting work showing how we may be able to intervene in the processes of immunity or to actually modulate Candida infection. So I'll finish the talk there, but I guess we've touched on a number of topics here. The first is the new therapeutic options for fungal infection, which include new antifungals, very promising, with improved or novel mechanisms of action, which will address some of the limitations of our current antifungal drugs. We can see that there are oral formulations of these newer agents. There's the opportunity to do intermittent dosing with those that the resofungin with the prolonged half-life, and several of these newer agents overcome current antifungal resistant mechanisms such as azole-resistant Aspergillus, echinocandin-resistant Candida, and some of the intrinsically resistant molds and yeasts. So these are quite exciting, and very much looking forward to the results of these phase 2-3 studies, which should all be coming out in the next 12 to 18 months. We've talked about the new data on the azoles, particularly Izabiconazole and Posaconazole, for the treatment of invasive aspergillosis. And I think a big area for future research will be on microbiome and how we can modify it to prevent infection, and to look at new treatment approaches such as adoptive T-cell therapy coming into more widespread use. We know that the technology is there. It's just a matter of making it more accessible to our patients. So I thank you for your attention, and with that, I will finish the talk. Thank you.
So, first of all, thank you to the 3 speakers. You were wonderful. I learned a lot. And I also saw many questions. I'm not even sure we will be able to answer all of them. I will start with the first one, not only because it is the first one, but because also it reminds me of my use in hematology and a stem cell transplant unit. So Esteban Arrieta Bolaños wants to know if there is any role for granulocyte transfusion in invasive mold infection. I would like to remember the people who are listening to us that neutrophil transfusion were done in the late 70s and 80s and then disappeared. One reason being that the half-life was only 10 hours. Also, the most effective neutrophil transfusions were coming from patients with chronic myelocytic leukemia, which cannot be envisioned anymore. but I would like to know if the three speakers can answer very quickly if they think that there would be some role for neutrophil transfusion, and maybe I add myself GM-CSF. So who wants to start? Olivier, maybe, if you hear me.
Yes, there are two populations. There are two populations in which we use granulocyte transfusion in desperate cases.
We cannot hear you.
Or rarely, as Fanny said, mucomycosis. So
we have some.
Can you hear me?
It's difficult from time to time. Try again.
Can you hear me?
Yes.
Okay, so we use granulocyte transfusion in case of desperate mold infections, either in CGD or in acute myeloid leukemia. We have not to forget that as hematologists, you know that it's not always good before allo stem cell transplantation for immunization reasons. So we have used it for few cases over the past 2 or 3 years.
Okay. And Monica, what would you say? Does it happen that you do that?
We do, but very occasionally. And we also use it, we must remember that there has to be an end point to it. So we usually use it when we expect neutrophil recovery to occur, just to support a patient until their neutrophils recover.
Okay, and what's the opinion of Fanny Lanternier?
Yes, in some refractory cases of mold infections with neutropenia, but very rarely, because we always fear the worsening for the lung infections after the granulocyte transfusion.
Yes, you think that we can worsen the symptomatology by infusing neutrophils. What about, I'm surprised by the answer because I thought that we would never use again neutrophil transfusion. But anyway, what about GM-CSF, which in the old days was recommended in some cases of infection? Would you still use it? I start with you, Monica, this time.
Thank you. I think it's actually hard to access now. The last time we tried to get it for a very difficult patient with disseminated Lamentaspora, we weren't able to access it. But I have used it in the past for these very difficult infections, in conjunction, of course, with the antifungals and surgery where necessary. But I think it could be useful as part of an overall attempt to improve a patient's immune response.
Oh, that's interesting to learn. What about you, Olivier? Would you fight to get some almost non-existent GM-CSF? Or Fanny, if you can hear us, because I'm afraid Olivier has some sound trouble.
We tried for a Card9 deficient patient at the beginning, and but we couldn't have access to GM-CSF.
Okay, thank you. So I'm going to the next question from Fabian Carles, and Fabian Carles, in fact, asked many questions. So I will try to select. The first question is regarding azole resistance. If the resistance is for mutation TR34, can I use posaconazole? What's the answer?
The answer is potentially yes. It depends on the MIC value for posaconazole, with a cutoff which has been documented in the literature to be 0.5. So if the MIC is above 0.5, there is no need to use it.
Okay, so now I have many questions going to the same issue, which is combination of drugs. I think, Olivier, you mentioned that you are against combination in one specific case. I remember in our own department at the time when I was chairing the Department of Hematology at Hôpital Saint-Antoine, that we combined in some patients voriconazole and echinocandins, and we were very, very enthusiastic about this, except that the hospital was very angry at us because it was extremely costly, expensive. So could you, I would say, give a short comment, the three of you, about combination? And I may start with Fanny Lanternier this time. What do you think?
Combination is only recommended in some very few cases. So in first line, I think we didn't really discuss these topics. That's recommended for cryptococcosis or for Candida endocarditis or CNS candidiasis. But I think for mold infections, there's no clear data that can lead to recommendation of combination in first line. That's only for refractory cases.
Monica, do you approve?
I agree. I think the only situation which might be a question asked later is with initial fusarium infection, where you're not sure whether to use voriconazole or amphotericin B. Sometimes I would use both in a very sick patient, but it's not my usual practice to use combination.
Okay. And Olivier, probably you will confirm what you said. I'm afraid we lost Olivier. I'm sorry. Okay, so I move to another question by Khalid Halahem. And you will see this one is really, I would say, almost everyday life in a department of hematology. I have a patient with primary refractory AML, neutropenic with 10% marrowblasts. He has subcutaneous lesions pathology proven, mucomycosis and aspergillosis with multiple bone lesions that may be chloromas. What would be the best approach in treatment? And the question is izabiconazole or other medication? I think I would add my own question, and my own question is almost the same one. If we have a patient with refractory AML and we want to do a sequential therapy, induction and directly stem cell transplantation, would you do it in the situation of these precise patients, yes or no? And if yes, what would be the drugs, the antifungal drugs you would use? Can I start with, let's say, Monica?
Oh, this is a really tough question. I think I would probably use high-dose liposomal amphotericin B to treat the mucormycosis, which would also treat the aspergillosis. I would try and surgically resect whatever was resectable, if possible, and if the patient was up for that kind of surgery. Certainly the subcutaneous lesion, it might be good to resect and try and minimise the burden of infection if possible. I think I would try and give the patient several weeks of high-dose antifungal therapy before contemplating going to a transplant. And this might be a situation where you might also think about granulocytes for this patient if they don't have a good granulocyte production themselves because of their myeloblasts. So I think it is a really difficult situation, and I'd be quite scared going straight to a transplant in this kind of patient. I would like to get a bit of antifungal therapy and try and reduce the burden of infection.
My only comment, I mean, I agree with you, but I would be concerned that if he has or she has a refractory leukemia, we may not have 1, 2, or 3 weeks before us to use only antifungal therapy. And we would probably go to both treatment, chemotherapy, transplant, and antifungal therapy, but I don't know. And Fanny, do you have an idea?
Yeah, I totally agree with what Monica said. Yeah.
Okay. Okay. Olivier, if you came back.
Yeah.
You are here. So what do you think? Did you hear us?
Yes, I could hear you. I also agree with Monica and Fanny. I would consider liposomal amphotericin B as the first drug, then long-term Izabiconazole or Posal now.
Right, but then I would ask another question because I think you are the one, I'm not sure, who mentioned that 3 milligram per kilo of liposomal amphotericin B was in what you presented, I don't remember which fungus, identical to 10 milligram per kilo. And I remember when I was younger that 10 milligram per kilo was used several times in view of severe disseminated fungal infection. So in this particular patient, would you use 3 milligram per kilo, or would you consider that 10 milligram per kilo is what to do?
I might go ahead.
Okay, so just to say that system has been studied in the field of aspergillosis and mostly pulmonary aspergillosis, so we don't have clear data if in CNS aspergillosis 10 would be better than 3. So that's my first comment. So in aspergillosis, in pulmonary aspergillosis, no evidence for the combination, and in crypto, no documentation showing that 6 could be better than 3 milligram per kilogram per day. So only in CNS mucomycosis, as Fanny said, is a recommendation today of 10 milligram per kilogram per day of liposomal amphotericin B.
Okay. So next, that's for Fanny. qPCR for mucomycosis. So Q means quantitative. Does this mean that you will follow the efficacy of the treatment by qPCR? Is it also not only a tool for diagnosis, but a tool for treatment?
So it's a good tool for follow-up. The data we have, because we have not so much, are that the negativation of the blood PCR is correlated with a good outcome. So I think the follow-up of the blood PCR is a good tool. But I cannot give you the reduction in CT that is correlated with a good outcome. I think we do not have this data.
Okay. So let me see. Now we have an anonymous question. I don't know where it comes from, but it's interesting. Again, what would be the best empirical antifungal therapy for a patient with suspected Candida auris fungemia in a resource-limited setting with only fluconazole, micafungin, and amphotericin B available? Who is going to answer that? Olivier, if you now are okay technically, what would you do?
A very tough question because it's already difficult to treat such an infection in a Western country. We know that more than auris isolates are resistant to flu. We know that several percent of isolates are resistant to amphotericin B, and fortunately outside the US, the resistance, at least in France, to echinocandins is not yet a problem. So I would say, according to what we can do in France, micafungin could be the I don't know what will say Fanny and Monica.
Okay, so quickly, Fanny, quickly, because...
yeah, I would say the same. Yeah, micafungin.
Okay, and Monica?
I agree. Yes, agree.
Okay, so the anonymous colleague got an answer. We have a good afternoon from Suzhou in China, a trainee of EBMT, Yuhua Ru, who says, now fungal infections are common in clinical practice and fungi resistant to azole are often found. So we agree. So what are the gene mutation sites of azole resistance? How to choose a combination, again, a combination of available antifungal agents to overcome these resistance. So this makes me think of one of your last slides, Olivier, but who wants to answer this?
Well, I might say something. I think that as Olivier showed, the TLR34 mutation is the common one that's associated with environmental exposure. There are other genetic mutations as well, and there are also different mutations associated with resistance in patients who've had long-term exposure to antifungal agents and poor clearance of the fungus, like with chronic pulmonary aspergillosis. So it really is dependent on the clinical setting, but in the hematology setting, probably the TLR34, and it might be worth avoiding an azole in that situation and going for amphotericin B-based treatment. But I'm interested to hear what the others say.
It seems to me that whenever we have trouble, we go back to amphotericin B. I mean, it's amazing. It's amazing to me. I have still two questions. So I think it's for you, Monica. You mentioned the microbiome, but biome, I don't know how you say that. As you know, the microbiome is of considerable interest in all diseases and especially in stem cell transplantation. And nowadays we are doing fecal transplants for many reasons, one being prevention of GvHD, and the second one, treatment of severe infection. Do you think the use of microbiome could be, in the coming 5 years, of the same importance as we do mycotransplants?
Well, I think I was pointing that might be something for the future. I think we're still very much understanding the microbes that make up the mycobiota and microbiota. So I don't think we don't know what we're doing if we give a fecal transplant. We don't know what organisms we're transferring. We don't know what long-term disease risks we might be transferring. And I think it's up to us to really study it better and to study the intersection of the immune response with the microbiome and with the intermediaries produced by the microbiome, such as all the chemicals produced that probably modulate the immune system. So I think maybe not in 5 years, but we may have a better understanding of what we need to do in 5 years.
Okay. So, and the last question, I remember at the BMT meeting a few months ago, there was a review also on therapeutics, antifungal infection, and I think it was Gerhard Henninger, but I'm not sure, who discussed antifungal CAR T cells. And you, again, Monica, I mean, you are the last speaker, and you talked about treatment. You spoke of T lymphocytes. Do you have any idea where we are for antifungal CAR T cells?
I think it's an idea at the moment. We see it written as a potential treatment that we could look at exploiting. I think there's a lot of knowledge about how to manufacture CAR T cells for a variety of different hematological targets, but we're not there yet with fungal CAR T cells, although I think it's a very exciting prospect.
Okay, so I think we are on time, and maybe we will say goodbye to everyone. For me, I have to express my gratitude to our three speakers. Thank you for accepting to participate. It is also my role to thank Air in Space, who gave us the unrestricted educational grant to build this. And also, I want to express my gratitude to CME Congress, which is very, very effective. So everything went well. So thank you all, and goodbye.
Thank you.
Thank you very much.
Thank you.
Bye.
Bye. Bye, everyone.